Hey there, welcome back to Basically EMS, the EMS podcast for all different level providers. Got some familiar faces you guys probably know. We got Kylee over here, we got Wade, and we got a new face over here. How about you introduce yourself?
My name is Justin Rainey, and I'm the director here at Idaho Medical Academy.
Can you tell everyone a little bit about your background so they know what you're talking about?
I would love to tell them about my background. You guys be prepared. This will be the whole episode, actually. So I was a paramedic for about 14 years. I worked for Ada County Paramedics. Also during that time, I was a tactical paramedic for that team. I was also part of their special operations team, which was the backcountry rescue team. Also, I did HazMed, so I worked on their hazardous materials team for a little bit, was involved with education. I started at CWI and teaching EMT programs that led to starting this company, and now here I am hanging out with you guys.
He was my EMT instructor.
Yes.
Oh, yeah, so this is the
10 years ago.
The old guy side that has taught you guys over there, essentially.
Exactly.
And then how long were you an FTO for?
I was an FTO for 10 years.
Yeah, so a little bit of time. Cool.
A little bit of time, yeah.
A little bit of time. So let's jump right into it. We're going to be talking about cold emergencies today. It's Idaho fall right now, leading into some Idaho winter. So this is a pretty important topic for us if you're working here locally or anywhere that gets real weather. So let's just jump into some things that some factors you might see that are going to affect those exposures that we're going to see, right? So first thing we've got here is going to be physical condition of the patient. So that could be illness, that could be other, pre-existing conditions like diabetes or cardiac condition. If they're just generally unwell, poor physical condition is going to make a difference. Age is going to make a big difference. I'm sure we'll touch on it more later, but just like I'm sure we've all been on the old person that fell down on the linoleum floor that wasn't able to get up. And that's, that can be a pretty compounding factor. So those are pretty big factors. And then along the age lines, also the very young. So I like to say we're born and we're babies and then we become adults and we turn into babies again, essentially, as we hit old age. And so the things that affect infants more significantly are usually going to affect the old folks a little more significantly as well.
And it's kind of slightly different, right? Because as we get older, skin gets thinner, right? We know that papery skin. It's a similar thing when it comes to the kids. It's more of a adipose problem. They have that thinner adipose, so they're not as insulated. And they also, just putting it out there, they got big domes. It's a lot of surface area to lose temperature.
Yeah, that's where we lose most of our heat from is going to be our head, and they've got big heads. And just the the body surface mass is much higher in little guys than it is in adults. So that's going to make them a little more susceptible.
Depending on how old they are, they might not be able to shiver either.
Yeah, really
that makes
little
a big
babies.
Difference.
They're a brand new baby. Their hypothalamus isn't going to be doing what an adult's would, and so they're not going to be able to self-regulate like somebody else would. That's why I'm sure, Justin, you've got kids. You probably have the same thing, like walking into Target and every single old person is like, why don't they have socks on? Like, we tried. We've gone through 4 pairs of socks just to get here, and they've thrown them all off, right? So it's important for the little ones to make sure that you're keeping that in mind. So keep that in mind, Wade, here coming soon.
And just to add to this too is anything about for physical conditions like comorbidities, just always have that as a high priority as you're thinking about it, just because it adds a little bit more dynamics to it, and just always think about it. But also too, think about with elderly too, like medications and stuff like that that can alter, and just be aware of like all the things you're dealing with. That's what makes EMS so fun, is that's just not one condition, right? We always deal with multiple conditions, from just the event itself to other kind of pre-existing conditions. That's what makes medicine fun and exciting to solve. It's not you just get one hypothermia patient. You get a hypothermia patient that might be a diabetic or might be elderly or an infant. And those things that you have to kind of think about and always be aware of how to treat these types of patients.
Right. Like cold is like almost a compounding thing on their pre-existing, right? They're hypoglycemic, but now they're also cold.
Yep.
Well, and like a lot of people forget about this, but alcoholics. Prime population for hypothermic emergencies.
Yeah. Yeah, and there's a lot that goes into that. Just beyond just the physiological side of things, just like the self-care and the motivation to take care of self, I think in some patient populations is down a little bit. And so maybe they're not, thinking about the correct clothing or those kind of things, and they're just kind of compounding as well with just the socioeconomic impact can be pretty big for these patients. So we might see that, from
That's
that
a really
to
good point. The socioeconomic status.
yeah, like
big one.
The old person that unfortunately is eating cat food because it's all they can afford on there. And it sounds like it's a joke. It's not a joke. We've all been on those patients where that's all they can really afford on their fixed income, and so they're not heating their home as well as they should. And that's that's going to that's going to be a big factor as well to think about.
I've been in houses too where like they couldn't pay their power bill.
Yeah.
And it was like December.
Yeah.
Or like some of these old houses here that haven't been remodeled, and the bench has houses that are in the 40s.
Yeah.
And they don't have good insulation or anything like that. I mean, that's what they can afford. Absolutely.
Yeah, single pane windows and all that. Like, these are all things that you should be looking at if you're a new provider and you haven't really seen this before. You should be looking at those things walking into the home, and it's stuff that we just do naturally because we've been doing this a long time, but you need to make that an active process doing those assessments as you walk into the home. Look at those things. How does it feel? If you walk in, it feels cold to you. That patient's been in that home for how long? Like how much are they going to be affected by that cold? So when we talk about that general impression, like we're not just talking about the patient, we're talking about all of those things. Like what are we seeing all together? What are we feeling? What are we smelling? All of those things can be taken into account.
Say rely on your senses. Yeah. And you hit it right there with smell, right? Like if there's a gas burning stove, you might be able to smell that, hopefully.
It's your spidey senses.
Yes.
It is.
The EMS Spidey senses.
Well, your senses are what's giving you your intuition.
Yeah.
So I always tell people, trust your gut. Your brain's taking in way more information than your conscious brain is.
Yeah, totally. And if you're new, it's going to take a little bit of time. So we get to the point, and I think I've told the story on this podcast before, like walking into an apneic patient and my brand new partner was like, "Hi, ma'am," and like introduced himself, or just I immediately was there. So it does take some time before you can pick up on those things. But if you're actively thinking about it, they become like a sixth sense eventually.
Yeah.
On nutrition, hydration is going to be an important thing. And then just alcohol in general. You're talking about alcoholics, but like current alcohol usage can have an effect on this. It affects how the body regulates temperatures and how you feel temperatures. So that can make a difference there. And then tight clothing can have a big effect for localized cold injuries. So that's something that you need to be taking into account that can aggravate those.
I always think of the girls that go downtown and like in January and they're wearing their super strappy heels and they're like super short dresses. I'm like, oh my God. I don't think, I get it, do it for the gram, but they're wearing the super tight strappies and then they're like, oh, I can't feel my feet. Doesn't help that it's also 30 degrees outside, but you're not giving your feet any circulation.
Yeah, you're already like the skin is already so shut down because it's cold, and now you're making it harder for blood to get there.
Beauty is pain,
Yeah,
and
yes,
pain
pain
means
is beauty.
losing your toes because you wanted
As
to
you
wear
can see,
the heels.
we all know all about beauty over here. We get it.
Because you want to hit the club. That's all.
Yeah,
My life is pain.
I would say like one thing with the hydration too, just to add on to it, is that people consider hydration differently in different aspects. I remember going on a guy who was like, "Hey, have you been hydrating?" He's like, "Yeah, I've been drinking coffee and that's all I drink." I'm like,
Claws.
"Oh, okay. Let's talk about that." Right?
White Claws have water in them.
Yeah, exactly. Yeah.
Yeah, or else it wouldn't be called White Claws, right?
Exactly.
White is because it's water and it's clear.
Exactly.
Right? Yeah.
Yeah.
Makes sense. Some other things to be thinking about, and this seems like common sense, but common sense isn't always there. Air temperature is something we need to be thinking about. Humidity levels can have an effect, and then wind can have a massive effect. So, be doing that daily assessment as you arrive on shift and thinking about like, what's it going to be like today? How cold is it going to be? If you're cold, they're cold, right? Like if you're going outside in a jacket, you should expect that the patients are going to need the same thing. So
Also a little scene safety plug there. Make sure you have your cold weather gear.
yeah.
You've got your gloves. I always kept hand warmers.
Yeah.
Your beanie, whatever your department puts in their uniform policy is being like, it meets regulation, but like wear your stuff. It's not worth it.
No, yeah. I mean, nobody thinks you look cool because you're standing there with like just your drop shirt on, or or just like your Class B uniform shirt on. Like you look like an idiot. Just wear your jacket when you need to be wear your jacket. It's a personal safety thing. So, and we'll get into this a little bit more, but so specific body parts are going to be the extremities, the ears, and the nose. All pretty straightforward. Like kind of thinner pieces of flesh, essentially. And then 5 ways that heat is lost. Somebody else want to I've been talking
Well,
about.
I want to backtrack to the body parts. We have listed on here just feet, hands, ears, nose, but those are the way I describe them is like non-essential to survival. Like they make being alive helpful for sure. They're helpful. Having hands is definitely a helpful thing to being alive.
For opening pickle
But
jars.
you could survive without them, right? Yeah, as you're finding
Yeah, if you
out.
only have one arm, then your very nice coworker has to put your headphones on your head.
Handy capable.
Yeah.
Yeah. But the non-necessity to life stuff. So like it's that shunting of blood. Let's keep the heart and brain and kidneys alive.
Yeah. Homeostasis is what it always comes back to at the end.
And just to add on to it too, especially when we're talking about treatment and stuff like that, especially when it comes to like the feet, hands, they're not, we don't need them to survive. So just remember, slow down. When it comes to a lot of this stuff, we're going to be talking about just slowing down. It took them a while to get cold. It's going to take them a while to get warmed up. So this is not an emergency. The thing I like about emergency medicine is that we train on the very acute, fast things that have to be really good in that split second, but also have to be good in that minute to an hour to 2 hours to 3 hours, right? We have to always be thinking about this kind of stuff. And this is going to be more of a delayed kind of like, let's slowly treat versus let's try to move and do everything so quickly, right? We don't need to warm up the hands as quickly as possible. We need to think about what organs are affected, the core. We're thinking about how to keep the core and the organs perfusing versus how can I keep my pinky finger to, perfuse, right? It's going to be a slow process, but we're always thinking about perfusion, really focusing on how can we stabilize that core. Yeah.
I mean, we've said it before, slow is smooth, smooth is fast, right?
Yep.
Like this is
Exactly.
double more important. Double down
more important.
when we're talking cold. Yeah, just take your time. Make the right choice the first time.
Yeah. Who wants to talk about the way that we lose heat?
I will. I actually feel
Kylee.
very strongly about this.
Good, because you're the only one.
Well, so it's just thermodynamics. That's all it is. And I'm a science nerd, so I really, really love this stuff. The way that I always describe it to my patients is like you just have to think about these big words that you see. Like they're just big words. Think about it conceptually. So conduction, I always say, you know how your seat gets warmer when you've been sitting in it? Excuse me. Well, that's because of conduction. You have direct contact with something. If I put my hand on this table beneath my hand, it's going to get warm. That's conduction. Convection is your good old AC. You have air moving. That air is hopefully going to whisk away some of that heat. And then, that's the whole premise for central heating and conditioning in general, but that's convection. Evaporation is your sweating. You're releasing that heat when you actually, when that water molecule evaporates or gets whisked away by something else. You have your radiation, which is why the room gets so hot when there's 22 students like there is in my evening class. The room gets so hot because you're just radiating heat. Your body is trying to meet the ambient air temperature. And then you have respiration, which is just the warm air that you breathe out. So if you think about it, I grew up in the woods. So I've had to think about literally every single one of these and do what I can to prevent every single one of them from happening. That's really what it is. These are just big terms. And the whole point is how your body is removing the heat from the body, whether it's by moisture, by air movement, whatever. It's really just an energy transfer. That's all it is. Heat is just molecules that have more activity or moving more quickly. You get rid of that, you even out the concentration gradient.
I think you brought up a really interesting perspective too. It's important to understand it, but also if you understand it, you can actually reverse it, right? So if you know the person's on the concrete floor, right, and there is conduction going on, well, the treatment of it is getting them off that cold floor, right? I think we always have to ask, like, how did they get there? But then how can we reverse it in a way? And so if you have a good understanding about what Kylee was talking about, I do feel like, hey, you have a solution of how to actually treat the patient is, hey, if they're on the concrete floor and it's cold outside, get them off the concrete floor.
Yep.
Oh, they're soaking wet.
Yeah,
Take their soaking wet clothes off.
Yeah,
Exactly.
You're out in the wind. Get them out of the wind.
Right.
Yeah, it's pretty simple when you break it down, but it can be a little intimidating, I think, to people first learning it.
I always think of convection as like the just kind of maybe it's another learning technique, but I think of it as the wind chill, right? You get out of the pool and there's that breeze and you're like, ooh, that was cold,
Yeah.
right? Same thing, or like a convection oven,
Yeah.
right? Your oven heats up the food with hot air. So just different ways. I think if they can, as the students, basic EMS students they go through, just find ways that it makes sense to you, right? Like we all kind of have our specific examples to come to mind. Find the one that works for you.
Yeah.
I always tell people breathing out your mouth is one of the worst things you can do in the winter, because respiration I think is really slept on. You know, that's part of where like the warm showers when you're not feeling well like kicks in, and like that you're supposed to breathe through your nose, and it makes a big difference. Like you were saying, there's tons of remedies for it. People just don't actively think about it.
Well, it's not like you have a choice, right?
Yeah.
You're gonna
Yeah.
have to breathe
Yeah,
on paper.
You know,
on paper.
That's what the science says.
people not thinking about what they're doing is a large portion of
Yeah.
why we are where we are.
Yeah,
So,
absolutely.
you know, that,
Yeah,
that helps
close
us
your
out.
mouths in the winter. Don't mouth breathe
You bunch of
anyways.
mouth breathers.
Don't mouth breathe, but especially it's just little things like that, you know. So you can encourage breathing techniques, even, which I've done with people, stuff like that. It's all in the small details.
I'm gonna be so self-conscious every time I run.
Hey, I'm getting mouth tape. I don't have any room to talk.
So moving on to local cold injuries. Who wants to talk about Frostnip?
I was
Cool.
gonna
Wade,
say
go for
Wade
it.
looks like
Yeah,
Wade
I mean,
wants
I
to.
can for sure. So Frostnip, right? That's like, I think of cold and heat emergencies, different topic, but I think of them as kind of progressive, right? And so Frostnip is kind of the beginning of that progression. So the body is starting to shunt blood away from those areas that are less important to survival. So nose, ears, hands, feet, right? But this is where with Frostnip, they start to have freezing of just the exterior layers. It's a freezing start, but it's not deep tissue death like you have with frostbite, like that black finger, right? Pretty common, ears, nose, fingers, like I said, with but usually not as painful, right? Because it's one of those, they're getting cold, so they're numbing, but they don't have that cell death. So the nerves are still functional, but they're numbed a bit. Versus cell death, right? As they start to die, there's that pain that progresses until obviously your fingers are falling off. And then
Frostnip is what you felt when you were standing out at the bus stop. And then you get on the warm bus and you're like, wow, my fingers and toes really hurt.
really hurts.
They really hurt. Yeah, because it's warming up again. It's not deep tissue. It's
that tingling in your ears. Wow.
oh, that's the
It's
worst.
only taken me 30 years and I finally put that together, huh?
Like I said, grew up in the woods.
Yeah. Fair.
And you love science.
And I love science.
Yes.
I do.
Nerd.
I know. It's helped you guys out a lot.
It has. We've learned so much already.
And then kind of just progressing, so trench foot is another one, right? So that's a cold water immersion. I like to think of it as more of just if you're soaking your foot in water for extended periods of time, that water is going to take your temperature away. So not only one, you're going to be pruning, your skin's going to be uncomfortable to the touch. You can start having cold develop with that. That's why, like, I know a big thing with like military guys, but like hunters, hikers, keep your feet dry, right? Make sure you're taking
Ultramarathoners.
care of them. Yeah,
I
extra
just
socks.
realized that ultramarathoners, this is like a big problem for them
That would make sense,
is trench foot.
right?
Because
sweating.
they're running 30, 40, whatever miles a day, and it's not until they get to the end of the day that they actually get to change their socks.
right.
I preach Lieutenant Dan through and through. Change your socks.
Change your socks.
Change your socks. That's why trench foot's what you're looking out for.
Yeah. And I mean, part of that, so pale, cool skin, right? So uncomfortable to the touch. And then loss of feeling to the injured area. That's obviously progressive as well. When I was a kid, I actually think I gave myself a bit of trench foot. I had an all-day soccer tournament, didn't feel like taking my cleats off. And I was just sweating in my shoes for 12 hours. And then the next day, I remember my feet hurting so bad, just to the touch, couldn't step anywhere. And that same thing, pale, really pruny look. It was awful. So I get it. Change your
Pretty sure
socks.
I got it from a a 24-hour shift at the busiest ambulance in the state of Idaho.
Change your socks.
Yeah, well, if we made it back to the station, I would have. But it was, it sounds ridiculous, but it was like July, and we were just there. Your boots are not breathable. That's the whole point. They're waterproof. They're everything proof, allegedly. I stepped in a large amount of water that was probably still water and probably had brain-eating amoebas in it. Honestly, I think about that a lot, but I could never, it could never dry because my feet were sweaty, and then I took my boots off when I finally got back to the station, and I was like, ooh, this is how trench foot happens. And it was actually very painful. I was really surprised.
Yeah. Makes you think about your choices a little bit.
Yeah, put the little dry things in your boots. They make a big difference.
Okay, you'll be able to see like pale is pale. You're like,
Yeah.
oh, well, I
Yeah.
have no circulation.
If you
Right.
Google pictures of it, you can see those ultra marathoners and those like long, I don't know what they're called for like professional cycling, but like, like the Tour de France and stuff like that. They'll show pictures of their feet and it's literally like white and gray just from where like their feet were exposed to the moisture.
Yeah.
It's icky.
It's gross. So frostbite is going to be the next. I like your thought with progression, especially because that's kind of how hypothermia too, right?
Right.
And so this is going to be, trench foot's its own thing because it's specific to like moisture. But frost snip's going to be the outside layer and then it's working its way in and it's going to be frostbite. So frostbite's going to be when the skin freezes. That skin is going to feel kind of leathery and thick, so it's not going to be as pliable because it's frozen, right? So it kind of makes sense. You can have superficial frostbite or you can have deep tissue frostbite. From my understanding, it's kind of hard to tell the difference between superficial frostbite and frost nip. They're more or less the same. It's just how far the layers are. And realistically for us anyways in EMS, does it really matter if it's frost nip or frostbite? It's all the same to us. We're going to treat it more or less the same. But it seems like a bit of a gray distinction between those two of when one becomes the next. But really for us, it doesn't really
Like burns.
matter too much. Yeah, exactly.
There's a picture in the slides and in the textbook that it looks like superficial frostbite. It almost looks like the guy has an abrasion on his nose. Older
The
guy.
Everest guy.
Yeah, it looks like he just biffed it on the sidewalk for a second.
And kind of, I think like the best way to even determine what the difference is just start asking questions in history, right? How long have they been out, right? That would be the biggest question. How long were they exposed for? Because the longer it is, the more of a history you can start leading up to like, oh, this might be more severe. Oh, let me do a physical assessment, right? Like, okay, hey, you have numbness or tingling, you can't feel this spot. It's or start to see blisters or whatever, right? Like, doing a good physical assessment and getting a good history, that's always going to be your priority when coming down to treating any person with a cold emergency is making sure that you ask the right questions and the right follow-up questions so you can get to see how sick this patient really is and how long they've been out for.
Yeah.
Right.
So working our way down, I think we have the deep tissue where stuff beyond just the skin is frozen. And so that tissue is going to be frozen. So again, it's going to feel hard to the touch, but again, kind of hard for us to differentiate when.
With the progression, depending on how long, that's when you'll start to see that necrosis of the tissue, right? So it gets that black coloration to it. Those fingers are getting cut off. That's kind of the way that goes.
Yeah, and I even wrote some notes here. I'm just going to read it because it'll be easier that way. But the changes in the water concentration in the cells cause changes in the concentration of electrolytes, which causes changes in the cell chemistry when this happens. So as the skin thaws, we have further chemical changes. That's what can lead to that cell death, is that those chemical changes within the cells as they freeze and thaw. It has electrolyte imbalance change and all that can cause that gangrene, which is that actual tissue death that we see in there.
It almost reminds me of like a crush injury. They have that metabolic change due to cellular destruction. Which
Yeah, it doesn't sound fun.
No,
it doesn't sound fun at all.
Well, I think that's to add into it is like that's why we're not rewarming them really fast or doing anything because we don't want to circulate all those free radicals inside the body, right? When we talk about like compartment syndrome or even post-cardiac arrest where it's like, hey, we get them back. We're not really trying to circulate a bunch of blood and get it. We're trying to stabilize them and slowly getting back and trying to stabilize those free radicals, especially when it comes to like hypothermia. We really want to slow that process down so we're not just, hey, let's try to rewarm it and try to push a bunch of fluid through and try to get, those free radicals and those electrolytes pushed through that body because you can cause some other complications too. This is one of those things like we've been talking about, just nice and slow. Your first thing when you're dealing with cold emergencies, just slow it down.
Yeah.
And just on something you said, for people who don't know what free radicals are, it's reactive oxygen species. So when an area is injured, oxygen will actually go to that area and it hinders tissue repair. So it's problematic, and that's what, like, we're not talking like the like woo-woo free radical stuff. We're actually talking about like oxygen when it's in high concentrations, it will flock to an area of injury and then won't let it heal. And that's what Justin's alluding to with the free radicals. Like if you do finally gain circulation back to an area, you run the risk of that increased oxygen concentration, which hinders tissue growth and then just furthers it. So that pertains to anything, heart attacks, brain injuries, like everything everything, but in particular, like these crush injuries, like Wade's talking about, and all that, you have to be really careful about recirculating these areas because you have the reactive oxygen species and also the anaerobic metabolism byproducts.
Yeah, that's been a huge change, I'm sure, more so on this side of the table from when we went through EMT school. But like, yeah, EMT school for me was like, oh, you stub your toe, well, you get an on-breather mask. Everybody like high concentration oxygen all the time, and we've really stepped that back because we found that that's not a good thing. So
Science for the win.
Yeah, see what I mean?
we're actually EMS is actually following science now, which was not the case 20 years ago. So it's helpful.
Well, the idea of just, progression, right? Like a lot of the stuff we deal with progresses to worse and worse things. But even our treatment, we can progress. Let's start small. We can always give more. We can always give more. We can't take it back once we've administered.
Yes, truth. So signs and symptoms, I feel like we've kind of already covered. It's gonna be that hard, waxy feel. Maybe blisters, maybe some swelling. One thing that that I have written down that we need to touch on too is that this can be harder to recognize in patients with darker colored skin.
Absolutely.
So darker skin pigmentations, we do not do a good job, and I've harped on this a little bit, I think, on the podcast, of training people to recognize signs and symptoms in people with darker skin tones because skins is such a huge deal we need to pay attention to. So this is another thing to be looking at. I'll do a double look in places where we would maybe be able to recognize, palms of hands, those kind of things for these patients, to look for those skin changes that maybe are going to be a little harder to pick up on a patient with darker skin tones.
And that's kind of the challenge. The challenge of, like, if you're not familiar with the pigment, what do you got to do to get familiar? Like,
I put something like this behind it so that I can look to see for swelling, for contrast.
I had a hard time. I think I might have mentioned it. I had a hard time telling what true pale was in Caucasian people for a long time, because I know what I look like when I'm pale, and it's not the same pale, And so that was something I like. Do they just not go in the sun? Is this normal? I don't know. Right. So get familiar, because it's going to make you a better provider.
As we talk about palms, I was going to add to it too, is like you can look at the palms too, but just see the range of motion, right? If they're so cold, can they actually make a fist, or is it painful to even do anything, right? So you can look always at the skin, but also think about like, hey, what would be normal in this? Can the patient form a fist, or if they're like, it's so painful or anything like that, or there feels like their joints are really stiff. Those are always great things when we come back to assessment, right? Like it really comes down to doing a really good assessment and thinking about everything you possibly can do to really point you into the right direction, because if you're in the right direction, you're going to do the right treatment.
Yeah, cool. So let's move on to some treatments for local cold injuries. We'll try to go through this a little bit quick because we're going to be a little pressed for time today. But the first one, the most simple one, is, as we talked about already, get them out of that environment. That's the best thing we can do right off the bat. If they're outside in the cold, lay in the snow, get them out of the snow, get in the back of your ambulance in a nice controlled environment. Remove wet or restrictive clothing. We talked about before that restrictive clothing can affect the circulation, so we want to get that off, as well as any wet clothing.
So those wet clothes are just going to make convection worse.
Yeah, it's just going to compound it, right? It's still going to, because if those wet clothes are more the temperature of the atmosphere, even if we get them out of the atmosphere, it's still going to be pulling the heat off of them. So we need to get that away. Yeah. So we need to get that away from them. And you should have lots of, blankets and stuff in your ambulance, whatever vehicle, to wrap around them and give them some nice, warm, cozy coverings.
Yeah, you're making your treatment even harder if you get them outside in the ambulance, but don't remove their clothing, right? Exactly. You're fighting against each other, right? If you're going to be a good provider, think about it like, hey, make the treatment work as effectively as possible. Like that's what, we love doing, is making sure that we actually do the right treatments and not fight against it.
I think if we talked about the ways to lose temperature earlier: conduction, convection, evaporation, yada, yada, right? But if we look at like the environment, so moving from the environment, that's a consideration we have as well. Like Justin said, they're on concrete. It's January. It's cold. Get them moved. Or they're wet. They're on a linoleum floor. They've been there for days. Get them moved, right? We know that's the reason they're losing temperature, so we can make a quick adjustment on it. And even our gurney with the blanket's better than that cold floor.
Yeah, and remember that the cold floor doesn't need to be middle of January.
Right.
A 70-degree floor in the middle of summer is still way colder than the body can handle. Just like you don't need to jump into an icy lake to get hypothermia very quickly. You can be in 75-degree weather. Like you can drop your body temperature significantly very quickly. So, just, something to keep in mind there. Working our way down, make sure that we protect if there is an injured part specifically protect that from further injury. So don't go banging a hand that has frost snip into the, the side of the gurney or whatever as you're
They won't feel it though.
That's true. They won't feel it right then. You'll feel it later down the line when the lawyers come knocking.
Yeah,
on.
right.
And everyone goes, oh, same time.
And then depending on protocols, you can also consider active rewarming. So if you have frost snip, you can put the patient, you can have them contact a warm object. I ride motorcycles, and there's been a thing a lot of the time for me that my hands would get really cold, and I would put my gloved hands onto my exhaust to start to warm them up. So something like that works pretty well. Or if, hot packs or whatever, just keep in mind the hot packs that we generally carry get to like 140 degrees Fahrenheit.
Yeah, they get hot.
Way hotter than you should. So make sure that those are insulated with like a blanket or something if you're going to use those.
It says have them tuck their hands in their armpits, and I think that's kind of a double-edged sword. Like, it might help, but it's going to cool them off, right? Because they're going to cool down blood circulation.
I think that's more specific, like, just the hands cold, whatever. They've been
like
outside. Or just, outside of a football game, not wearing gloves,
Yeah.
and they're complaining about, then you can kind of tuck them in.
Fair enough. Fair enough.
And then, let's see, for Immersion Foot, make sure you get rid of that wet clothing. And then, as Justin was saying, everything rewarm gradually all the time. And then cover loosely with a dry, sterile dressing. You don't want it to be too tight again because it's going to affect that circulation. There might be some swelling that happens, so make sure it's nice and loose. We're never going to rub or massage any of these areas. You're just going to, if it has that dead cell nastiness in there, we're just going to release that all to circulate out. So we don't want to rub or massage. We're going to remove jewelry or tight clothing, just kind of in general, again, with any swelling that might happen or cutting off circulation, we want to remove that.
Doubling down on dry dressings as well, right? Because we don't want to lose more temperature with the potentially moist dressing.
Yeah. Yeah, definitely. As like my favorite way to remember that is if it was wet, then keep it wet. If it was dry, keep it dry.
Yeah.
And
Oh, that is good.
you know what I mean? Like, and generally things are going to be dry. So we're going to keep it there.
Yep.
So for frostbite, again, cover with a dry, sterile dressing. Don't break those blisters. Just leave them, let them happen how they're going to happen.
Any blister.
I mean,
Just
for us,
yeah.
any blister, just leave
Yeah,
it. Yeah.
just leave it alone.
Yeah, you don't want to cause an infection or anything like that.
Yeah, the ambulances are not very clean. None of our stuff is very clean. Not even if we try our best, it's just never going to be that. It's never going to be even close to sterile. And then this one's pretty.
I have a question. So, Justin, we were talking about rewarming the other day, just kind of passively. You said it was something like a degree every hour or something that in the ER.
Oh, yeah. So I was talking about when we do like cardiac arrest. So when we get people back from cardiac arrest, there's a thing called ROSC, which is basically they have a pulse again, but they're starting to do therapeutic hypothermia. So we actually do like medical cooling bodies down in the hospital and stuff like that. And that's to help with free radicals and stuff like that. But what they're working on is a normal body temperature is anywhere from like 36 to 37 Celsius. I'm going to use Celsius for the science person.
Fancy.
Yeah.
37 is 98.
That's what I was going to say. It's around 98.6.
Yeah.
I knew that too.
So, but we're cooling patients down to like 32 to 34 now. But what their recommendation is cooling them down to that degree for 12 to 24 hours, and then gradually rewarming them for 8 hours by 1.2 or 0.2 to 0.5 Celsius per hour. So what basically that whole transcribes into in the formula is warm up slowly, right? Cool them down, but warm them up slowly. And that is like the medical, like hypothermia to keeping them warm. But I also think it's a kind of an interesting thing to think about is because there's not really anything of saying how fast do we need warm. There's nothing especially in EMS books and stuff like that. Is like how fast do we rewarm them? I'm just kind of taking that literature and saying, hey, this is a slow process in a medical state, so we probably should kind of keep it in that same realm of, hey, this is a slow process. We don't have to be like, hey, we have to get 1 degree up every hour or whatever. It's more like, is this person comfortable? Are we maintaining vital signs? But in order to do that, we have to take it at a slow time. Places here, we can get to the hospital in 15 to 30 minutes. Places where, maybe where you guys work, it might be 2 to 3 hours. So, always kind of be prepared. It's like, it's not always about like getting a victory and making sure they're, we got them back to a normal temperature. It's slowly making them improve. We're trying to keep these patients in the game as much as possible so they can get better care because there's going to be other things that they can do at the hospital. But the reality of what we're working is this is a very slow process. You might not actually see the full, oh, we got them back and everything's fine and they have good feeling. This is going to take a while, but that's all right. And so don't ever think like, oh, I didn't do a great treatment because they're not back to a normal thermic temperature. Hey, are they getting warmer? Are they improving? Yes, then you're doing great EMS. That's what, think about that.
We're step one in the chain.
Yeah.
It's good for our bodies. We like to be cold way more than we like to be hot. I mean, we do that for a reason, right? So just remember, they will get warmed up. It doesn't have to be done by you. It's best for their bodies. It's exponentially better for their brain if you just let them warm up in a controlled way. You don't have to rapidly warm them. That's how you can induce seizures.
Yeah. And per the text I was lecturing on this today, the only one that we actively truly rewarm is mild hypothermia. Like they're at that 95 degrees. That's when we can throw some hot packs in the armpits or on the groin and let's get that temperature up. Everything else, gradual. Put them under, warm up the ambulance, keep them under a blanket, and then just get them there. And that's when the hospital's going to step by step get them to where they need to be.
Yeah, I mean, realistically, we're not going to even find a good core temperature, right?
Yeah.
Like the hospital's going to do like a urinary catheter or something to get that good core temperature. We're flying blind in a lot of ways, and so it's better to be a little more cautious about it.
We carried rectal thermometers.
And how many times did you use those? Wayne?
I was about to say, I actually did it a couple of times. And the majority of them were on hypothermic patients. Those of you that are listening, don't look at me like that. It's necessary for some people. It's necessary for babies. Like you have to do it for them. But also if you're going to actually quantify your potential field diagnosis, you got to get a temp. And rectal temps are the preferred method. Your patients are going to be unconscious. If you are getting a rectal temp on them, they're going to be unconscious. It doesn't have to be. It doesn't have to be this weird thing. You should get it because, again, you're just trying to quantify things. And we're all about proving like, hey, this was their core temp. Here's why I did what I did. It's not that bad.
And they usually have different thermometers too. So
Yes,
so you don't use the mouth and the rectal at the same time.
I've put the wrong one in someone's mouth before.
I've done that too.
For sure. The only way to tell the difference is the taste.
You guys are animals.
Well, no,
Barbarians.
it was my first clinical, and the nurse was like, "Oh, get a temperature," and I'm getting a temperature, and they're all laughing at me, and they're like, "You put the rectal." I'm like, "No one told me." They're like, "This is always the red cap." I was like, "No one told me that." They
We
just
don't
handed it.
have those in the ambulance. We have a box with Sharpie on it that says rectal, if it even says that.
I had the exact same experience with thermometers in the clinical. They're laughing at me. I'm like, well, what? And this lady for sure had 3 teeth in her head. And it was one of those where it's it's probably not the worst thing she's put in there.
What you really need is wade around just to taste the difference.
Yeah.
To tell you which one's
I
which.
knew one of you was going to say that. And
He already made the joke. I'm just bringing it back.
It's awful.
I'm proud of it.
That makes me
I
violent.
stand by that.
Also, too, I mean, this is a call I had, but guy was laying on the floor, in the middle of winter, super cold, urinated on himself, just been there for a couple days. We get him out, get him in the ambulance. We do to panic. We're like, let's see what it is. It was 82 or something like that. And the first thing we were like, this must be broken. Remember, sometimes your equipment actually works. It's not you. It's not, you want to say it's not me, but it probably is you.
Right.
Yeah. So, if you see things that are different and stuff like that, and you're like, this doesn't make sense, maybe you start questioning doing more of it. So this guy, we actually got a temp of 82. We tried to put him on the EKG monitor to look at his heart, and he was so cold that it wouldn't even actually pick up on the monitor. He was so cold, and then we ended up getting an IV on him, but we had to go through his neck, and then we tried to run it wide open, and it was just drip, because his blood was so thick, and they ended up getting a Foley temp of 79 degrees, and he was still alive. He didn't know where he was at, but he was still moving around and everything like that. So
That's impressive.
But it just goes to say, just because you see a piece of equipment that tells you a reading, and you're like, don't always be like, that must be broken, because it sometimes happens. We're like, maybe this can't be right.
Trust but verify a little bit there.
That's why we always double check when the firefighter gives us a blood pressure.
Yes.
Always.
That was Kylee that said that.
Yep,
for everybody
I
listening.
said it.
That was Kylee.
Yep.
just to kind of finish off with Frostbite too, if you do get an order for rewarming, which I never worked anywhere that would have been a thing, but maybe if this is like a search and rescue team or something, you would have the capability to do this. But you're going to do a warm bath no hotter than 105 degrees, and continually put that affected part in that water. It is going to be incredibly painful for these patients. It's excruciatingly painful. So keep that in mind when that's going to happen. It's not going to be fun for them. But after that, you'll put, again, the dry sterile dressing and covering over it. All right, cool. Thanks, everybody. That was part 1. We'll be doing part 2 in a couple days, so keep an eye out for that. We'll be talking specific about hypothermia. So this was just those local cold injuries. We'll jump into hypothermia for part 2. Check it out. We'll post it where this is posted. So YouTube, Apple Podcasts, Spotify, all that. We'll see you there. Thank you, guys, for being here. Thanks for Justin, of course.
Thanks for having me, guys.
We'll see you guys in part 2.